Hello, welcome everyone, and good evening. Thank you for your being here, for joining us for the first European webinar of Norlase. It is all about SimplyInnovation in retinal care, so advancing the clinical practice across Europe. It's hosted by the Ophthalmologist, and I'm Kathrin Benedikt. I'm the Regional Director of Norlase, and I would like to give you some small information about Norlase itself. Norlase is a Danish company. It's located near Copenhagen. Everything is developed and manufactured in Denmark, and it all started on the Technical University in Copenhagen. So the special thing about Norlase is the new innovative technology with a semiconductor diode, and therefore we can produce our lasers very, very small, which makes a complete change in daily practice because we just simply do not have any external fiber cables and that basically cannot break. So today we have three speakers, three completely different speakers, which I like very much because we have also three different topics to talk about. The first speaker is going to be Professor Stanga. He is from the Retina Clinic London from the UK. Our second speaker is Dr. David Borroni from Bologna in Italy. And our third speaker is Dr. Alexander Thrane from Tonsberg in Norway. And they will all be presenting about the difference in our Norlase lasers. So we are going to start with Professor Stanga, but I would like to let you know up front to the audience. First of all, thank you very much for joining. And we do our question and answering session after all the three speeches. So you can listen to all the three speeches, and afterwards we do our question and answering, and you can put your questions into our chat. So you will find a little chat place where you can mark your questions. If you like, you can address it to the speakers, to the speech that you are interested in, and we will cover your questions later. But I will guide you through that. And yeah, I'm going to start now with Professor Stanga. Professor Paulo Eduardo Stanga is actually the founder of the Retina Clinic in London. With more than 30 years of experience in ophthalmology, he focuses on the medical and surgical retina, including, for example, macular degeneration, diabetic retinopathy, vitreous floaters, cataracts, retinal lasers, and many more. He is an absolute expert in the field of laser indirect ophthalmoscopy, which he's going to speak about today as well. Professor Stanga is actually committed to advancing the world of eye care, and he is dedicated to transforming lives through his pioneering work in ophthalmology, especially also in respect to his independent clinical and research fellowship program at the Retina Clinic London. There are over 100 peer-reviewed publications that you will find with his work included. But I personally think Professor Stanga's secret is his educational power, the combination of his expertise and his willingness to share it. Professor Stanga, the floor is yours.
Thank you very much, Kathrin, for that undeserved introduction, and thank you to Norlase and the ophthalmologist for this opportunity to share with you our work combining the use of indirect laser with scleral indentation and ultra-widefield imaging with Navigate peripheral OCT. So let me share with you how we indicate treatment and how we monitor our patients. So these are my commercial associations. I have to disclose that I'm a consultant for Norlase. So let's start with retinal examination. What is a pan-retinal examination? We all talk about retinal examination, but unfortunately, we all know that most retinal examinations are limited to slit lamp biomicroscopy. And we also know that this is not enough, because really, when we talk about retinal examination, we should be examining up to the ora serrata. That is a full retinal examination. And there's no handheld lens that allows to see the ora serrata in vivo. And we do not want to miss tears, holes, or peripheral lesions. It was Charles Keppens in 1945 who created the first headset binocular indirect. When we look through an indirect, when we look through the handheld lens, we have to remember that the view of the fundus is going to be both inverted and reversed. What lenses do we use? Well, we have several lenses. We can go from 14 to 40 diopter lenses. The most common are the 20 diopters and the 28 diopter lenses. I use myself a 2.2 lens, and that gives me the field of view of a 28 diopter lens with a magnification of a 20 diopter lens. And I use a socket depressor for scleral indentation. Back in 1998, I started OCT scanning. We were very happy at the time to obtain 400 A scans per second. Nowadays, we are scanning at speeds of 100,000 A scans per second. And we are using mostly swept source technology. And swept source uses infrared illumination and high scanning speeds. So that allows us to visualize in detail the vitreous, the vitreoretinal interface. We can also now do OCT imaging, not only of the macula, but also of the peripheral retina. And back in 2023, we published our 3D rendering of peripheral retinal lesions using OCT. We rely on an everyday basis on the Silverstone device, and this allows us to obtain ultra-widefield multi-wavelength imaging or ultra-widefield fundus fluorescence angiography or OCT angiography with navigated central or peripheral OCT. And we published our results back in 2024. Going back to the indirect ophthalmoscope, this is the only way, as I said, to visualize the retina. So this is a very essential skill. And it is very important to be able to use confidently an indirect, because that's what we need in order to be able to do indirect laser retinopexy. Here, this is a case. You'll see when I present the case that I'm showing also how many spots I've applied, the pulse duration, and the intensity, the power that I've used. In terms of spots, it's whatever it takes to surround a lesion completely. In terms of pulse duration for PEXI, I use 200 milliseconds because I want a scar that is going to stick the retina and do, as I said to the patient, spot welding. And indirect with indentation, I think it's essential because I want to laser all around the lesion. This is a patient that was referred to me with laser just to apply to the posterior edge of these two horseshoe tears. And this is not enough because fluid tends to go under the retina, under the flap, and under the anterior horns. So it's important to laser the anterior edge, and this is not usually possible unless you use indirect laser. You can see how many more details I see when I indent and when I play with the sclera, indenting the sclera. We can see the lesion from every angle. And indirect ophthalmoscopy coupled with ultra-widefield imaging and navigate peripheral OCT is also a good way of looking at these lesions, because I can assess whether there is a vitreoretinal attachment, whether there is traction, and it helps me to decide which lesions I need to treat and which lesions I can observe. So I started using indirect laser technology from Norlase when they released the Lion laser indirect ophthalmoscope, and nowadays I'm using the Lynx device. The Lynx is, as you know, the first indirect ophthalmoscope with a pattern scanning laser technology. And this is the setup in my office. Here you can see the pedal, you can see the tablet through which I can control, even with voice control, rather than needing to touch the screen. This is the 2.2 box of my lens, the socket depressor, and this is how I do the laser, and this is the couch in my office. So let me go through some examples. You'll see always the settings that I've used. This is a horseshoe tear, and here you can see the effect straight after the laser, and this is 1 month after the lasers. We want to see the pigmentation, and we want to see pigmentation all around the lesion. Another example, here you can see a large horseshoe tear, 1, 2, and this area is already subretinal fluid. This is already a subclinical retinal detachment. You can see the attachment of the vitreous, and this patient needs urgent laser. You can see the laser goes right up to the ora serrata and even around the area of detachment. This is the area of fluid, and this was successfully treated with indirect laser retinopexy. There is discussion about round holes. Do we need to treat them or not? Well, indirect ophthalmoscopy is, of course, the method of choice to assess these lesions, but also Navigate peripheral CT shows that there is a vitreoretinal attachment and the presence of subretinal fluid, the full thickness hole, and therefore this hole, in my opinion, does need treatment. The presence of pigmentation, we have to remember, does not confer protection, because pigmentation means chronicity. It means that there's been traction there for a while, stimulating the RPE cells to proliferate. And PEXI is different. PEXI will give you a guarantee that the fluid will not continue to expand. This is a patient where laser was carried out only to the posterior edge of this area of pigmented lattice with a couple of tears. And you can see here the traction. So the navigated OCT confirms the presence of traction, and I carried out indirect laser PEXI all around this area. And if you just treat the posterior edge, this is not incomplete. This is not complete treatment, and you are not conferring protection to the patient. This is a case where the patient presented to my clinic prior to undergoing an ICL implantation, a high myop, and you can see there is an area of lattice and what appears to be a tear there and a hole, and you can see that there is this area is already elevated and there is a vitreous attachment. So I carried out laser all around this area. And the only way to do this successfully is with indirect laser delivery system. Another round hole with a more significant amount of fluid and a second lesion here. You can see how I surrounded all the area. Here you can even see the ora serrata with navigated ultrawidefield imaging, and you can see how my laser treatment reaches the ora. And you can easily know that you are reaching the ora because not only you see the limit, the demarcation, the boundary between the pars plana and the retina, but you can see how when you carry out the laser, the pattern is completely different. And you can see the pigmentation a month later. Lattice degeneration with a hole and schitic changes, what appears to be schitic changes, but OCT shows that there is already a detachment in this area. And you can see the pattern of laser that I've applied, how I carried out laser all around the area and the pigmentation a month later. Another example of lattice, elevated lattice. You see the chronicity here. You can see intraretinal fluid, but you can see that there's a significant area of detachment in this associated with this lattice. And you can see a nice but large round hole. So all this area was surrounded by laser. And here you can see before and after. Here I'm working with the Lion system, and this is before and after. can see the before and after on indirect ophthalmoscopy. So it's essential to carry out laser all around the lesion. I don't do 360-degree laser just in case. I just treat the lesions that need treatment. Another example, this is a pigmented lattice, and there's a large tear all along the area of lattice, and again, all around the area of lattice. This is a case of peripheral retinoschisis accompanied by an area of detachment. So I've surrounded the area of detachment and all around the area of schisis, because we know that laser cannot stop retinoschisis, but it can stop the progression of the secondary retinal detachment. And I would like to finish with two examples of treating peripheral vasculopathy. Here, this is a patient with proliferative diabetic retinopathy, but the neovascularization of the disc would not regress, and I therefore carried out peripheral laser. I completed the panretinal photocoagulation up to the aura, and the only way to do this is with indirect laser, because no contact lens allows you to reach the ora serrata with panretinal photocoagulation. And you can see here the effect of the scattered peripheral laser once there has been pigmentation. This is before the laser, so this is the area that I treated, the peripheral areas of non-perfusion, and the regression of the neovascularization at the disc. And it is important not to continue treating the mid-peripheral retina, because all you achieve is this kind of treatment. This is treatment carried out elsewhere, but this right eye of the same patient has significant loss of visual field. By treating the peripheral retina, you preserve visual field. And my last case, a patient with juvenile rheumatic disease, peripheral retinal vascular changes, exudative retinal detachment, exudative cyst and vasculitis, and indirect laser around the area of cyst and within the area of cyst. And you can see here immediately after the laser and sometime later, you see the resolution of the cystic changes. So dilated slit lamp biomicroscopy is not enough. Indirect ophthalmoscopy with indentation is an essential skill, and indirect laser is the only way to successfully treat retinal lesions. Thank you very much for this opportunity.
Thank you very much, Professor Stanga. That was a very impressive speech with very nice cases. And I mean, as a producer, Norlase, having the world's first pattern LIO, I think it is a huge improvement also in the speed, you know, from your treatment. And I think this is a take-home message for our audience, is to learn, I think, that LIO is not only there for RP treatment with premature babies, it is also for adults, especially also diabetic patients for the future. And Europe is still in the process of, as you said, confidence, you know, confidence is needed, and there is a little bit more of education needed. And we are working on that. So I invite all of you to try out the links. It's a fantastic device. And thanks to you, Professor Stanga, for giving us such a nice insight of your daily work. Perfect. So I'm coming over to the next speaker. Our next speaker is Dr. David Borroni. He is from Italy. David is actually a cornea and cataract and refractive surgeon with a practice focused on corneal transplants and complex anterior segment surgeries. And he is board certified in ophthalmology in UK, Italy, and Latvia. Actually, David graduated in medicine at the University of in Subria in Italy back in 2011. and then achieved his CCT in ophthalmology and his European PhD at Riga University in Latvia. Afterwards, he moved to the UK and completed a 19-month fellowship in cornea, cataract, and refractive surgery at the Royal Liverpool University Hospital. And last but not least, in 2022, he opened his own private practice and is now dedicated to advancing patient care. So David also received several awards, including, for example, the ESCRS Clinical Research Award back in 2018, and also in 2021, the Macedonia Award from Italy. So, David, let's welcome you and take it from here. Thank you very much.
Thank you very much, Kathrin, for this wonderful introduction. And thank you, Professor Stanga, for your previous presentation. It was very, very nice. So from a cornea side, you know that we have to manage retinal disease in our office. So I try to show my experience with the Norlase laser. I have to say that I have no financial disclosure, especially with the Norlase as well. So this is my own experience and practice. So first of all, if you come from the cornea side, you have to understand that the first question is, do they work? So does the laser work and for what actually? So we have to, it's a very, very basic introduction. So we have to use for retinal disease and as well for anterior glaucoma actually. This is my experience, and the first things to say about the Norlase, the first thing that I really like is the way that it is very light, is 1.36 kilos actually. And the technology, the microsec mode actually, that I like because it's saving the tissue in the retina. And it is very user-friendly, the interface, very, very user-friendly. And here it's possible to see a small video actually how in a clinical practice I can choose and I can see my display. And on the top left, I can set and I can choose all my settings, especially the micropulse in the macula and the microsec for the glaucoma treatment. And I can choose the grid and the spacing between all the dots, actually. So these are the things that I really like quite a lot of the display and how does it work. And the choice that I can do, and especially on setting the interval of the millisecond, that it can help a lot your life during when you do your laser procedure, actually. So this is something a little bit different from other instruments on the market. And these are the things that I like more of the laser. Of course. So when many times you see some macular disease, so these are the settings that I usually like to use to treat some macular edema. And now I will show you some cases. So in my office, sometimes there are multiple cases of a chronic retinopathy. And usually they come from other offices, so they are very unsatisfied patient with previous treatment, and sometimes nothing works actually. So here we decide to do some laser treatment, some microsec treatment, and after 2 months, you can see that on the top images, you see the pre-operative laser treatment, and after the post-operative laser treatment. And this is a chronic situation. It was standing for more than 6 months, actually. So the laser, it was the one thing that resolved our problem. And especially if you are focused on anterior segment disease, to have something that is able to fix in a quick time, for us, a very serious posterior disease, this is very useful and very helpful, actually. But sometimes we like to observe other cases and to see how is the timing actually that do you need to treat this anterior segment, this posterior segment disease. So these are another cases of chronic maculopathy, a serious one, and you see that after 5 days of treatment, you can already see some reduction of the water and of the edema under the macula and under the fovea. So you can understand that after a few days, the treatment is starting to work actually. And this is pretty nice for us because we can see some result. And usually you have to consider that these patients usually are quite anxious actually, because it's linked to this disease. So to show them that something it is working is quite helpful for all of them. But Sometimes this is another case that I used to treat. And when we do cataract surgery, sometimes we have some Irving gas syndrome, or sometimes we have some chronic macular edema, maybe after 6 months or after a year from cataract surgery. And as well, using this laser, the microsec in the macula with the sectin that I showed before, it is pretty helpful, actually. Usually, this patient, after a surgical procedure, they are not very happy of the outcome, of course, because the light is not able to go up to the retina. And if you are able to remove, let's say like this, the fluid inside the macula to restore physiological macula, they are very happy, and actually you resolve a problem and the patient is very happy with you. But sometimes we have to go a little bit forward. Sometimes we have some patient that maybe you have to choose some treatment they are not very keen, like the intravitreal injection. So sometimes we understand that we don't need to be perfect. We need to be close to be perfect, actually, and we have to choose the best solution for the patient, actually. So in some posterior cases of uveitis, we were able to use the macrosec. In some patients that, of course, if you see like this, probably the IVT is the best solution that you can use sometimes, but the patient was not really keen to have another injection into the eye. So in a posterior uveitis, chronic one, we were able to reduce the edema in the macula and in the fovea area, actually. So this is something that makes us pretty happy, and we do with the Norlase ECHO at this time. It's possible to see here in the OCT, actually in the left side, you see all the red area is all the edema that is present into the retina, and in the right side, after a follow-up, it's possible to see that the edema is quite reducing. So the patient reduced the edema, so the vision improved, and the patient as well, they were pretty happy. So which area, how to treat? Sometimes you can see in many meetings, they speak to treat the central area, sometimes between the vessels, the arcade of the macula. So I like to treat the whole retina, actually, when I'm trying to treat a microsec, so between the vascular area, so around 6 millimeters. And this can help sometimes as well in a little bit more advanced situation where, of course, again, here, probably you have to consider it to treat the diabetes in the background, to do some peripheral laser as well. But the patient was not really happy to have intravitreal injection. And here as well, treating all the area, the peripheral one, and with the microsec between the arcades of the macula, we were able to obtain pretty good result. Especially here, you can see after the laser treatment, the result, they were acceptable, let's say. Here there is no perfection, but at least they are acceptable, and the patient will start to see some improvement, actually. As well here, the patient, he didn't like to have an injection into the eye. They're pretty old, they're around 84 or something. So the treatment, the microsec on the macula, is possible to see that there is a reduction, actually, in the chronic situation of the maculopathy. Here, of course, linked to age. As well, postrum is another case that we are able to treat, of course, with the microsec. This is after a few days, actually, and they were all chronic situation, actually. So it's possible to see that the microsec, it is working in multiple situations, probably because we are going to stimulate and to treat. So, of course, this is another topic that we can afford, but just to show our experience with the Norlase ECHO laser microsec treatment, that it was working pretty well, as well in the post-thrombosis, actually. Pretty hot topic, actually. In many meetings, you see drusen, dep. Actually, there are many ideas, of course. So we tried in some advanced cases to treat the whole center part of the retina, so the whole macula area, and we were able to reduce actually the presence of the drusen actually in the area, in the center area. Of course, we are even using sometimes other machine actually to help, but this case was treated only with the Norlase microsec treatment, and we were very happy with the result. Of course, there is some actually degeneration of the epithelial pigment that, of course, can improve the final outcome, but actually the patient, they were happy, and it's possible to show them actually that something is changing and they're reducing the shape of some disease inside the macula. Ocular hypertension, of course, is quite a huge problem. anterior segment practice, and we have started to do some comparison between the MLT and the SLT. And the simple things to see is that there are not many published articles comparing, doing a quite diffuse comparison. So they are pretty few at the moment, but for our experience, they work equally. So if I can say something, it seems that the MLT is, the SLT is a little bit more aggressive, actually, it seems, and the MLT is a little bit soft. So it's possible to do some wise treatment. Sometimes you can do a double treatment on the same times. From my experience, try to reduce as much as you can, actually, the intraocular pressure. Here it's possible to see that there are not really many studies, but from our experience, they work equally, actually. And here it's possible to see actually the setting and all the things, because sometimes some people, they are scared about the intraocular spikes, but actually they don't happen quite often. So with the MLT, you can go very easy way. Okay, thank you very much for your attention, and I was inside the 10 minutes.
David, thank you so much for your really nice and speech and your very impressive cases. It's always good, I think, to see these OCT images prior, pre and post. For the audience, it's nice to visualize that microsect treatment has a big impact, actually. And I have the feeling that microsecond treatment is getting more and more attention, because you're just stimulating the retina and you don't harm it. So I think this is a very nice and interesting topic that everyone is going to be fascinated and interested about it. And thanks for your insights also, and your demonstration with our Norlase intuitive pad. It was very nice that you did a video on that to show everyone. So yeah, thank you very much. Our last speaker for today, before we are going into the question thing, is Dr. Alexander Thrane from Norway. Welcome, Dr. Alexander Thrane. He is a consultant ophthalmologist, and he's working on one hand for the Memira Clinic in Oslo and in Bergen, with clinical focus on cataract, refractive, and glaucoma surgery. So both David and Alexander are actually not retinal specialists, but cataract and refractive specialists, which is really interesting. On the other hand, Alexander recently also founded his own private clinic in Tonsberg in Norway, where he uses the ECHO laser device. Dr. Thrane is a trusted expert and specialized in cataract, refractive, and glaucoma surgery, and he brings years of hands-on experience in private and university hospital settings. Furthermore, he is a fellow of the European Board of Ophthalmology, and he holds a postgraduate degree in refractive surgery. His research background at actually leading institutions such as the University of Oslo, Copenhagen as well, and Rochester underscores his authority in advanced optical imaging and also neurophysiology. On top of it, Alexander is sitting at the board of a charity organization called Right to Sight, and they do a lot of surgical but also educational work in Kenya. Now I'll hand over to you, Alexander, who you will share your experience with the Norlase ECHO laser, and I thank you for that.
Thank you, Kathrin, for that great and probably undeserved introduction, and thanks to both the other speakers for great lectures. I think a lot has been said already, so I will keep mine a little brief. I was asked to hold a lecture on the utility in a busy clinical private practice, and here are my disclosures. None are really that relevant for this. I will be speaking about the ECHO platform a little bit more in technical detail because I find the lasers fascinating, and then about the clinical utility, and then about the business case for having such a laser, because I think the size format and the pricing makes it extra relevant for anterior segment surgeons to integrate into their practice. It reduces the threshold and broadens the scope. And then I have a few case examples, and then I've included some of my suggested settings at the end, but they're very close to Davide Borroni's, I think. I think we already touched on this. The main difference with the Norlase ECHO and Leaf is that they are very small and very light, and this is possible because of the diode laser. They have voice command, as mentioned by Professor Stanga, similar to the Lynx and the Lion. And they are mainly designed for retinal treatments, but also have effective use in micropulse for glaucoma. The interesting advances in laser means that everything is getting smaller and smaller, and a lot of this comes from the progress in lithography, in making chips very small. So I did my PhD in Rochester. We worked with multiphoton lasers, and the laser cavity and the lasers were much bigger and had more parts that could break, and the lasers were mainly moved by galvanometric mirrors that have more inertia and again have parts that can break. And the Norlase distinguished itself by having a very small diode laser and MEMS, or microelectromechanical systems, which is a small lithography printed mirror that moves the laser in the pattern scanning. It's also fiberless, so you avoid the issue of damaging the fiber optic cable, which can happen with the lasers. And as shown by Dr. Borroni, the tablet has a very useful interface. In a busy private practice, I find the number one priority is to be able to deliver treatment to the patient efficiently, to have a short pathway from decision making, from looking at your imaging, to turning around and then delivering the treatment, so that you can then get on to your next patient whilst still providing excellent care. So it looks a little similar to Professor Stanga's unit what I saw before, but I have several equipment on the same unit, and I just flip the laser around when I see something that needs to be treated. So for instance, if someone comes in the evening complaining of floaters and flashes, and I find a retinal tear, I find the size format of the ECHO is such that it is on my normal unit. So I just flip the triple unit around, and then I do the laser, and 5 minutes later they're out of the office. So it shortens the pathway. I think I borrowed some slides here, but the pattern. So I had the Norlase Leaf, which is the one without pattern before I had the ECHO. And the pattern laser makes it much more efficient to do micropulse treatments, but also to do PRP, pan-retinal photocoagulation. What would maybe take you 15 minutes before could take you 5 minutes for a sitting of a pan-retinal photo in the amount you could do in one sitting without inducing too much macular edema. The thing that I'm sure most experienced laser clinicians are aware of is that as you have a larger pattern, the exposure time gets reduced for each individual spot, and then you have to adjust your expectation as to the thermal effects of the laser. So when we initially got pattern lasers, I think, at least in my clinical experience, some of the issue was that we were used to having maybe 100 millisecond burns that have they stay pretty much the size they are, or can even have some creeping if they're deeper, to going down to 50 millisecond burns or less, where sometimes the size of the laser spot is actually smaller than the white area that you treat. So this is worth considering, for instance, with pan-retinal photocoagulation. I find the patterns also help ensure that there is healthy tissue in between, so you don't create these huge zones around the vascular arcade, right outside the vascular arcades, where you've created visual field defects, which some of the older lasers used to do. So I use it for panretinal photocoagulation, sectoral photocoagulation, laser retinopexy for tears. Traditional grid laser I've basically stopped doing because I find the microsec is much less harmful to the tissue, but it is possible to do this. And then I use it for MLT, micropulse laser trabeculoplasty, and I think the ideal candidate for MLT in my hands is the pseudoexfoliation patients. They respond very well. I think as we were discussing micropulse, it is worth noting that our microsecond pulsed laser, the reason that you don't get the burns is because you have these intervals between the pulses, which causes there to be no heat buildup. So basically, it's a sufficient laser effect for the retinal pigment epithelium to produce heat shock proteins and activate this pathway that stimulates them to absorb fluid, but it doesn't create a burn or damage the tissue permanently. I have just some images that I've borrowed as well, but I just find it useful. The more I use the pattern laser, I find that looking at my older treatments without the pattern, they look a little disorganized, as you can see in the comparison here. I'm unsure if this is the experience of everyone else, but I've found that the way the beam path is set up on the Echo allows you to have oblique illumination whilst still the laser is coaxial with the eye, so it's easier to get peripheral burns with this one, but obviously not far peripheral, as was discussed earlier. Some other lasers, the beam path is also coaxial with the illumination path. So if you want oblique illumination in a quadrispheric lens, you also then get an oblique laser spot. A lot can be said about wavelength of lasers, but the Norlase, because of the diode's characteristics, is a 520 nanometer laser, and I think this is useful to know. This is in the green spectrum. There has been a lot published on the difference between green and yellow lasers, but to my knowledge, the discussion about how much more or less patient pain is experienced between the different wavelengths is less and less sure these days. In my hands, it seems to be more to do with your exposure, with the settings of the laser itself, with exposure time and things like that. The 520 at least overlaps nicely with the absorption of melanin in the pigment epithelium, whilst some of the yellow lasers would theoretically create deeper burns in the choroid capillaries. And I think some of this has been mentioned before, but I've just taken some pictures of state-of-the-art competing platforms such as the Navilas and the Pascal. As you can see from the images, most of these are larger platforms. They sometimes need a dedicated laser room. And for instance, with the Navilas, which has a very neat navigated system, you'd wind up spending quite a bit of time planning your treatments. And in my hands in a private practice, that's time lost. If I can see the image on my Optomap or something on the screen right next to me and then just do the laser. And here are some of my brief case examples. The images are taken from Nidek Glavas, the new OCT from Nidek. This is more of a discussion point for later, but I think there is more research needed in where microsecond laser might fit. Because I think a lot of people currently use it for patients that are unable to get intravitreal treatment or where they are incomplete responders to intravitreal treatment for edema of various sorts. But from colleagues in cancer research, for instance, there might be scope for further benefit if you combine different things, adjuvant treatments. So I think there is scope for further research in the combination and what sequence is best, which treatment to have first. I've experimented a little bit with doing microsecond pulsed laser, for instance, in patients post ILM peeling, retinal membrane peeling. And I have another nice image of central serous as Dr. Borroni mentioned, responding quite nicely to microsecond. The main argument in my eyes for trying microsecond is that the alternatives, thermal laser, focal laser, or PDT, are, if you look at a retina that has been treated with either of these modalities 10 years down the line, the issue of damaging the pigment epithelium creeps up. So in summary, I enjoy using the platform for its portability, efficiency, and versatility, and I think it offers a good business case for a cataract and refractive surgeon. We do need to have an opinion about the retina, and without a retina, you can't see very well, irrespective of how nice a lens you put or whether you replace the endothelium. And I think the patients appreciate having the care within one pathway. Here are my settings that they can be sent afterwards. Thank you for your attention.
Fantastic, Alexander. Thank you so much for your valuable insight information, and also for showing how you adjusted our laser into your private clinic. And it's all about efficiency, you know, simplifying the life of everyone is actually the main target of Norlase. So it suits in your setting really, really well. And I think also our take-home message here is that not only retina specialists, but also cataract and refractive surgeons are in need of a laser, or at least can take it into consideration to help their patients in a very fast and efficient way. Fantastic. So thank you for all your wonderful presentations. Time goes really fast, but I think now it's time to get some questions popped up. So if I stay with David and Alexander, both are dedicated to your presentations, and I think you can answer that. The first question is actually which lens is used for MLT, and to repeat the MLT settings. I think maybe you can do a follow-up, and then afterwards David can join in.
I could show the slides again if you prefer, but I was gonna say I could put the settings after. I'm sure David has similar ones. I use the Retina but what does David say? The Retina ocular, yeah.
Yeah, I use the same, but many times I use the Goldman, the three mirrors of Goldman that I like to use as well, that one. But of course, the one you're using is pretty good as well. I mean, you have to adjust a little bit the setting, but yes.
I guess it's useful because on this last slide that was shown very briefly, that you have to be mindful of the magnification, because the SLT, the Retina lens, has a 1:1, but this is the same when you treat the retina. You know, you have to be mindful of what happens to the laser spot with the various lenses.
Okay.
Yeah.
Oh, go ahead, David.
Yeah, sure. I agree. So the only thing is that you need to be very careful when you are treating the retina, and because of course, if you change the setting, it's changing quite a lot. But the things that I'm looking for, my experience, that in the anterior parts or in the trabeculatus, you can choose a little bit higher spotting, higher power, and everything, and that you don't find usually many problems, as you sometimes you could find with the SLT actually. So I think the MLT is a little bit more permissive, so you can use a little bit higher power, I think. So sometimes with the calculation of the lens, of course. So this is the main difference, I think, between the SLT and the MLT in my experience, actually.
Okay, great. And then I will continue with the next question, because that also refers to PRP and actually a leaf or an echo. There was the question, which is the best lens to use for PRP for a good peripheral cover? So all of you can give your insights or your personal opinion about that.
think this question is for Professor Stanga.
Or for Professor Stanga, yeah, well,
professor.
yes, that's true. He's the retinal professor. You can answer that as well, Professor Stanga, of course.
Thank you for that. I personally use the Mainster 165. I think it has the largest field of view. We have to remember the magnification factor of each lens, and this has a magnification factor of approximately 3 times. I think it's always important when we use a pattern that the pattern that we use in the, close to the arcades in the periphery is not the same as the pattern that we always use in the very periphery because of the curvature of the eye. So sometimes it is always easier to use a smaller pattern, for example, to move to 2 by 2 in the extreme periphery rather than the 5 by 5, so that all the spots reach the retina with the same fluence, the same intensity over an area of tissue. And it's important to bear this in mind as we go along the curvature of the eye. I always start the treatment titrating, and we have to remember that some patients have different pigmentation in different areas of the eye. So we have to be mindful that we have to play with the intensity of the laser, the power, as we go along during the treatment. When I work within the arcades, I tend to use an area centralis.
Okay, great. Thank you very much for your insight. And if we stay with you, Professor Stanga, how do you compare the use of pattern versus single spot in an LIO regarding treatment efficiency and especially also safety?
Well, the now availability of a pattern technology in applied to an indirect ophthalmoscope is really fascinating, because we've been waiting for this for a long time. And as you said before at the beginning of this webinar, this is not important only for our colleagues who do ROP, but also, for example, in diabetic retinopathy, because indirect laser is the only way to treat diabetic retina up to the aura. And this can become very important in a young patient where we do not want to reduce the visual field. In terms of safety, it is as safe as single spot. There's no reason to be different. Of course, we are delivering the treatment in a faster way. And Alexander talked about pain, and we published our work on looking at pain some years ago. And it is important to deliver the treatment in a short period of time before inflammation sets in the choroidal tissue. When inflammation sets in and temperature goes up, that's when the patient starts perceiving pain. Also, of course, when we are delivering treatment along the ciliary nerves, the long ciliary nerves. So having the availability of delivering the treatment using a pattern will certainly allow us to deliver the treatment in a faster, in a shorter period of time.
Yeah, actually, that was one of the next questions that just appeared here in my box. Have patients commented on the comfort or experience compared to traditional laser treatments? But you answered it already, that the comfort is higher, right?
Absolutely. I no longer do peripheral treatment with a contact lens. I've stopped doing that a long time ago, and peripheral retina is better treated with an indirect ophthalmoscope laser.
Hey, and one of the other question was, what is the best and definite treatment for a retinal hole? I can address it to all of you, but Professor Stanga, you can also go ahead and if you like.
Thank you for the question. Not all retinal holes need to be treated. That's the first thing that we need to understand.
Right.
Routinely treat retinal holes because otherwise we would be treating everybody, and we don't every retinal hole needs treatment. I only treat retinal holes that that are full thickness with already subretinal fluid. And I always tell the patient, we can either monitor you or we can treat. I think treatment carries a very low risk when done correctly and not too intense. And it avoids having to monitor the patient, because it's very difficult to know what patient needs to be monitored and how often. The other reason that I choose, other reasons that I consider when are factors I consider when trying to decide whether to treat a retinal peripheral retinal hole or not is whether the hole is superior or not. Inferior hole, less likely to need treatment. Absence of PVD, a posterior detachment, is another reason to treat. Once there is a PVD, most likely the hole will not require treatment.
Great, great. Thank you. Thank you very much. So let's see, what else do we have here? Speaking of efficiency, how it impacted time efficiency in the surgery when you started to use the Norlase laser. Any of you? I don't know. This is not dedicated to some of you. You can, David or Alexander, you can also, David, maybe you want to answer that?
Sure. I think efficacy is pretty high because it's pretty quick actually to use the laser to turn on, turn off the treatment. So I think it's very, very easy to use, very user-friendly. And if you need a little bit of experience with normal laser just to place the lens, or if you want to use an indirect ophthalmoscope. But speaking about the laser, I think is pretty easy to use. Just switch on and let's go. I think so. I think is one of the highest point this laser efficiency.
That's great. Thank you very much. Another question was coming to you, David. After a treatment for CSCR, how long do you normally wait for doing a follow-up, and after what time do you see a result? And do you retreat, or like have a retreat interval, for example?
Yeah, sure. So usually I wait a couple of weeks before doing another OCT, actually 10 days, couple of weeks, but usually to see the full result of a laser treatment, usually I can see it in a month, between a month and 2 months, actually. I don't retreat so often, actually, around 5-6% of cases. And if I have to do it again, I do after 3-4 months, actually. But if I don't see any result, like 0, I try to change therapy. If I see some reduction of at least like 50, 60 or 80%, or I wait a little bit more, or sometimes I do some additional treatment, but no more than 2 times in my experience, actually.
Okay, great. Great. Thank you. Thank you very much. And now I have a very interesting question here. It says, during indirect laser delivery with scleral indentation, how stable is your aiming beam in real time? When the eye moves with indentation, is there any lag or drift in the aiming accuracy of Norlase? Or have you seen targeting mismatches between what the surgeon sees and where the laser actually lands? So this is probably dedicated to Professor Stanga.
That's a very good question. The answer is no. I think the accuracy of the laser is very good. Of course, it is user dependent. It will depend on your skill, your experience, but there isn't a lag. I'm not concerned about that. We have to remember that we do not need to achieve a cartoon-like appearance of the laser spots where you have perfectly placed 2 by 2 beside another 2 by 2 and another 2 by 2. But when we are treating a rheumatogenius horseshoe tear, what we want to do is place spots all around the lesion, and certainly, without any doubts, with a pattern of 2 by 2, we are going to place more spots in a shorter period of time. In terms of the eye moving, if you are indenting, you are securing the eye. So it's very unlikely that if you are doing it correctly, that there's going to be movement there, unless you are moving the eye with the hand with which you are indenting. But otherwise, I don't see that as a concern.
Okay, that's perfect. Thank you very much. Now, there are some questions that we cannot take now, but we will answer all of your questions later on for sure. It's also regarding slit lamps, how many slit lamps are compatible I have seen, and especially the treatment settings for CSCR. But we will send this information later on. We will publish it, and then you have access to all the answers from our speakers here. And yeah, unbelievable, but it's already 8 o'clock now. The 1 hour went by like this. And I have to say that I'm very honored to be moderating the first European webinar with such wonderful speakers here. I think we all learned a lot, and I hope our audience is happy about also the different approaches, and you all learned a little bit more about Norlase today. And I really want to thank all 3 of you for being so helpful and supportive here, and for giving such a great presentation and insight information. So thank you very much.
Grazie.
Yeah,
Thank you.
yeah. And I wish you all a wonderful evening. And yeah, let's stay in touch. And for the audience, have a very nice evening as well. And thanks for joining our webinar here. Bye.